Now we are inviting another our innovator, Rajendra Prasad. You must have heard his heart nucleus management. Now he is going to show you swing machine capsulotomy. So he has many innovation in his name. So this is something different you will find. Normally, all of us are doing capsulotomy by different ways in hypermature cataract. Simple cataract, no problem. You can do any type of capsulotomy. In hypermature, there are many techniques. We all must be trying some different techniques, double capsular X-rays, or several things. So he has devised something which is very commonly otherwise we are doing. But he has devised something which is easily available and we can do it conveniently. Rajendra Prasad.
Good morning, friends, ladies and gentlemen. Thank you, Dr. Satanshu Mathur, for the nice words, and I thank you for keeping me in this beautiful IC. The talk is on saving needle microcapsulotomy. So we do not have any financial interest in the subject matter of this presentation. We all come across these intumescent pearly white cataract, and they generally present to us in a different form. It could be intumescent soft immature white cataract, where you have a hyperhydrated fluffy cortex. You may come across with intumescent mature white cataract, where you have a swollen flocculent cortex with very voluminous soft nucleus. It could be intumescent hypermature white cataract, where you have a partial cortical liquefaction. It could be intumescent extremely hypermature white cataract, which is also called as a Morgaginian cataract with total cortical liquefaction. So how to differentiate them? You can use OCT. The OCT images can differentiate the type of the cataract. And secondly, you can find out in these immature hyperhydrated cataract, you can find out the fluid pockets, where the fluid pockets are then in the cortex. And we all know that all of these cataracts, they have a similar character, that is thin fragile capsular bag. And secondly, they all have a very high intralenticular pressure. So what happens when you puncture these white cataracts with a needle, when we use the 26 gauge needle or the capsular access forceps, you would see a volcanic eruption of the fluid which comes out from the capsular bag. This is primarily because there is a high pressure in the capsular bag, and there is a fluid filled capsular bag because of the pressure, and this pressure releases from the point where you are puncturing it, and the fluid comes out from that point. But this does not happen always, because many times what happens when you puncture, you could see that with the release of the pressure and the fluid, the capsular puncture which you have created on the capsule, on the anterior capsule, starts extending to the periphery, and it transforms in this kind of radial complete tear in the anterior capsule. So this is commonly, we all come across this situation, and this has been described as Argentinian flag sign by Perona in somewhere in 2000. He said that it's primarily because of the raised intralenticular pressure and release of the pressure which creates this extension of the capsular tear. So this used to be one of the very common complication, and most of the common complication in intumescent white cataracts. The percentage of incidence is almost 28.3% of the cases would come across this problem. That is the reason, because of the complexity of this situation, many innovations have taken place. And we all have come across, and including this small needle aspiration technique, we all have been doing till now. But what happens with the small needle aspiration also, when there is an optimum intralenticular pressure, even with the small needle, the moment you puncture, the capsule starts extending to the periphery, even before you could aspirate the fluid from the intralenticular space. So what actually the presupposition is, like it's not only the intralenticular pressure, there has to be some other reason also for the extension of the capsular tear. So we actually published this technique, saving needle microcapsulotomy, and we have given some physics about this. And the reason for that we found was, it's not only the intralenticular pressure, it is the configuration of the tear what you make on the anterior capsule. So what device you are using to puncture the anterior capsule before you start the capsular axis, whether you're using the needle or capsular axis forceps or something else. So what we have seen actually, when you're using the capsular axis forceps or the needle, you puncture the anterior capsule, you're actually creating a cut on the anterior capsule. So this is a linear cut on the anterior capsule. And similarly, when you use the capsular axis forceps, we tear the capsule before we start the capsular axis. So similar kind of cut you make on the anterior capsule, then we start the capsular axis. So what happens if you create a cut on the anterior capsule? This has a more proficiency to extend to the periphery because it's a cut. And if you have a pressure inside, the cut will easily open up. And this, what happens because of the pressure, when you make a cut on the anterior capsule, this cut opens up, the two edges of the cut opens up and extend to the periphery. So this actually is the reason why you get the Argentinian flag sign. So we had a hypothesis that instead of making a cut on the anterior capsule of this kind, why not to make a hole before we start the capsular axis? So what we did, we devised a device. This is a device, this is called the swaying needle microcapsulotomy. And you can see the tip of this device is round and pointed. It's not unlike the needle, which is a sharp tip, which has a sharp edge like a knife. So when you puncture the anterior capsule with this device, you will make a hole on the anterior capsule. Unlike when you use this, we'll make a cut on the anterior capsule. See, you can see the difference between the configuration of the puncture we make on the anterior capsule. One is hole and one is cut. The cut will open up, the hole will have a more resistance against any kind of pressure which is there in the interlenticular space. So this hole will never extend to the periphery. It will release the pressure in the capsular bag, and when you release the pressure, then your capsule will decompress, it will become flat, and then you can start the capsular axis. So this is what happens, like when you puncture with this device, you make a hole, and the hole will release the fluid and the pressure from the capsular bag, and your capsular bag is decompressed, then you can start the capsular axis. So I'll go to you can make one puncture or you can make multiple puncture also, but the multiple puncture, when you make the multiple puncture, it has to be within the 5 millimeter zone. You don't make it beyond the 5 millimeter zone. Many times you have a multiple fluid pockets in these cataract, so you can just find out the pockets with the OCT and then you can puncture these points to release the pressure. And to start the technique, you have to fill the anterior chamber with good viscoelastic, stain the capsule, and then this is the device. And this device, how to use this device is important. And you'll see the next, because when you go inside, you have to keep it vertically positioned and puncture the anterior capsule. And the fluid, you can automatically comes out, and many times you have to milk it out, like you have to use the visco cannula to milk it out, because the peripheral fluid, you have to bring it to the center, and that fluid will come out from the capsular bag, out of the capsular bag. So these are the multiple situations where you puncture the anterior capsule and you release the fluid like this. And once you complete the decompression of the fluid, this is how you have to milk it out. The fluid in the periphery will come out. And then you fill up the anterior chamber again with the viscoelastic, and then make a cut from that puncture. Now you don't have to worry, because now your capsular bag is completely decompressed and the capsule is flat, and you can very safely start whatever size you wish to make a capsular axis of this particular case. So to conclude, this is a very simple device, because just 1 rupee sieving needle, you can bend the tip and you can use directly. That also can be done, or you can take this device is available with Epsilon, and you can use this device for puncturing the anterior capsule. So it's very highly effective. This technique has been awarded the best film at the AIOC this year, and one of the best technique was declared. Thank you very much, friends.
Thank you.